So our next session, next 20 minutes will be spoken by Mrs. Emily Engstrom from USA. She is a senior manager in clinical services and operations, Emory University Hospital, Winship Cancer Institute, Georgia, USA. She's going to speak about, as we know, the radiation therapy is one of the main modalities of treatment in cancer patients. So she's going to speak about the basic principles of radiation therapy, radiation safety, and nursing interventions for skin care and mucositis associated with radiation therapy. Mrs. Emily Engstrom, please.
Hi, good morning or
Good morning.
afternoon for you. It's bright and early here. So thank you for having me, and I'll go ahead and share my screen for you. So again, thank you for having me. I have been a radiation nurse for about 22 years now. Absolutely love the field. I love the technical aspect of it, and I hope that I can share a little bit of my knowledge from my years of experience with you. So first of all, quite a lot of nurses are not familiar with radiation. Um, they've worked in oncology for years and they may work in the medical oncology area or the surgical oncology area, but they don't get a chance to see radiation. So they don't really have a good understanding about what happens here. It's all kind of a mystery. So, just a basic radiation are high energy particles that are used to damage or destroy cancer cells or the abnormal cells. So, we do treat benign diseases as well with radiation. And so those are just abnormally dividing and growing cells, just as the cancer does. The radiation directly damages the DNA of those cells and creates free radicals that in turn damage further DNA. And when this damage occurs, those abnormal cells will then die. They're not able to repair and rebuild. Our normal healthy cells have normal DNA and it's able to repair and rebuild. So there's a lot that we do, and we'll talk a little bit about that to help that process take place. So there are a few types of radiation that are commonly used. External beam is the most common. Here in the US, we have a couple of different types of external beam treatment. Typically, photon and electron beam therapy are the most common. Photon beam treats deeper tissues, and electrons treat superficial tissues when we're only trying to get within a couple of centimeters below the surface, either the skin surface or just below the skin surface. We use electrons. Otherwise, we typically are using photons. We are very fortunate here at Emory to also have proton beam therapy, and protons treat in a whole different way, in that we have less of an exit dose of that radiation. The dose of radiation is delivered directly to the tumor, and then the dose rapidly falls off so it doesn't then exit the body, and create side effects from that. We also use radioactive seeds. These are when we want to get the radiation as close to the tumor as possible, again, without causing damage to surrounding tissues, typically because there are highly sensitive areas, such as in the prostate. We would like to spare the bladder and the rectum when we're treating the prostate, so we're able to place those radioactive seeds either directly within the prostate or within an applicator that allows us to um, offer the radiation to the prostate without leaving it behind. And we'll talk a little bit about that in a minute. There's also systemic radiation, which is an injectable form of a radioactive substance, such as something like iodine that's used to treat thyroid cancer. There are other types of systemic radiation, such as strontium. Strontium is used to treat patients who have myelomas. It can be used. There are other treatments that are used to also treat patients who have widespread metastatic bony disease. So a couple of different things and different precautions that come up with those patients. So why do we use radiation therapy? We have a couple of reasons. We have a curative intent. So we may be using the radiation with or without chemotherapy, and we're intending to actually cure the cancer and prevent it from ever coming back, and or prevent it from coming back as long as we possibly can. We have local control, which is when the radiation is intended to just stop the cancer from growing, um, and and this would be such as in a late stage breast tumor that can't safely be removed by surgery, in a bladder tumor that's not able to be removed by surgery. Also, in sometimes we have head and neck cancers, such as those that are near the larynx, when we don't want to do a laryngectomy, and we may just treat that with radiation to provide local control depending on the patient's status and situation. We can use prophylaxis. That's when we treat an area with radiation, and we want to prevent any microscopic cells that may be in that area from then developing and creating tumors. We see this commonly in small cell lung cancer. Small cell lung cancer loves to metastasize to the brain, and so frequently we will treat the whole brain with um, radiation therapy to prevent those cells from turning into tumors. We also have palliative intent radiation. When we treat palliatively, our patients receive radiation to help with side effects of their cancer. We're not intending to cure them, we're not intending to provide really any control of the disease. We know that the disease is going to progress, but we want to give them the best quality of life that they can have. So they may have significant pain and not want to be on high doses of opiate narcotics. Um, so we can treat those areas with radiation and provide some pain relief. Also, if they have a large tumor, such as compressing the superior vena cava and causing symptoms, we can treat that as well, and provide some relief there. Benign diseases we commonly treat are things like keloid scars, or heterotopic bone. These are just overgrowths of tissue, and the radiation will halt that overgrowth and prevent those from happening. So, as far as radiation safety goes, this has really changed over the last 22 years that I've been in radiation. Um, External beam has always been very similar to the X-ray radiology departments. Um, when the LINAC accelerator is on, that's when the radiation is being delivered and emitted. We are not in the room with those patients so as to avoid any dose of radiation to the staff. But those patients are not radioactive. There are no precautions necessary once they walk out of that room each day. There's no issue with radioactivity. And this is a common question from patients. They don't understand how we can give them radiation and then they're not radioactive or they're not carrying around radioactivity. Um, the radioactive beams actually do the damage, and then when the beams are turned off, the radiation's gone. I usually use an example of a light bulb with our patients. When I turn on the light, it's there, and when I turn it off, it's gone. So that helps them understand that process. When I started in radiation, the brachytherapy that we did, that type of radiation where we want to place radioactive seeds in the tumor or as close to the tumor as possible, we mostly did what was called low dose brachytherapy. This is where we actually did a couple of things. It's commonly known prostate seed implants, where we will place radioactive seeds actually within the prostate. When we do that, those seeds are left there for life. They never come out, they stay with the patient. They will decay over time, and so the patient does have some radioactivity, and we teach the patient and the family about that up front when they go home. They can go home, but there are some precautions they need to follow. Um, and then we also used to use it very commonly for GYN cancers. We would admit our female patients to the hospital, and then place applicators where they needed to be. and then place those radioactive seeds in those applicators. Patient would stay in the hospital for a few days based on the dose. We would time it so that we would know when to go back and retrieve those radioactive seeds. We would retrieve them and then remove the applicator, and the patient could go home. Again, they're not radioactive because we're taking those seeds out. But it did cause some level of dose to the staff when we did that. Now we almost exclusively use high dose rate brachytherapy. This allows us to place applicators where we need those radioactive seeds to go, and then we're able to place the patient in a safe room, connect them through transfer tubes from those applicators to what's called an afterloader machine. Then we come out, close the door, and the system sends those radioactive seeds into the applicator as we prescribe for the different times of dwelling in the applicator to receive the proper dose of radiation. So again, no risk to the staff, and the patient gets the dose of radiation where it needs to be, and then that radiation goes right back into the unit. It never touches the patient, it's not contaminated in any way. And then they've received the dose and they can go home, and they're again not radioactive, so they don't have any precautions to follow. So it works very well. One of the very common side effects that we see with patients is mucositis. It's commonly caused by the radiation to the mouth and the throat areas, the nasopharynx, oropharynx, hypopharynx. Those are the most common areas. We can also see some changes when we're treating the rectum or the anus in those mucosal tissues as well. But for this purpose, we're talking mostly about oral mucositis. Patients will have a decreased taste, dry mouth, thick mucus, mouth sores, risk for bacterial and fungal infections. So we want to pay attention to that. We want to be aware of that very early on and be proactive so that we can help prevent any really significant effects from the mucositis. Some of the interventions that we actually recommend are dental care prior to the start of radiation. Even here, that can be a luxury. Many patients don't have dental insurance here in the U.S., and so it can be difficult for us to find a dentist who's willing to take them on. But we do like to try and get them looked at and make sure that they're not having any major issues before we embark on this radiation therapy with them. We also recommend that prior to starting their radiation, they begin rinsing their mouth at least 3 times a day with a baking soda and water mixture. This kind of helps create an alkaline environment within the mouth and helps prevent some of that mucositis, as well as improve. There's some anecdotal evidence that helps it improve cell death with the radiation in an alkaline environment. As far as the baking soda and water mixture goes, I think about everyone has their own recipe for that. I was always taught anywhere from an eighth to a quarter of a teaspoon in about a half a cup of warm water. What we typically recommend for our patients is that they use a refillable water bottle, and they make at least 24 to 32 ounces of this water mixture and keep it with them during the day, and just rinse their mouth as often as possible. Helps keep it clean, and it's just a great thing for them to do throughout the course of treatment. We also recommend that they use a soft or an extra soft toothbrush so as to decrease any abrasions to the gum and tissues, as those are going to become more sensitive, and a low fluoride toothpaste if possible. We do want the fluoride. The fluoride has a tendency to burn those tissues, so we want to be very careful about that. So if that becomes an issue and they notice they're having burning, we'll switch them to a non-fluoride type toothpaste. We also recommend avoiding alcohol. Any citrus and alcohol includes anything that's in a mouthwash or fluids that they're going to drink, any type of alcohol. Citrus foods, tomato foods, spicy foods, and extreme temperatures on their foods can also be difficult for their tissues within their mouth and increase that mucositis. We have something here that we use called Magic Mouthwash. Again, this is another one of those little concoctions that just about every oncologist I've met over the years has a little bit different formulation that they like. So I'm happy to discuss that with anyone and give some recommendations if you need something different. But there are all sorts of things that can help. It helps take down the inflammation. Um, Kind of helps with pain directly at the site of pain, and then also helps provide a little bit of light numbing so that a patient can eat a little more comfortably while they're going through treatment. So um, that's where I have to end for this portion. I'm going to talk about skincare in another section here, but hoping to answer any questions that you may have about this kind of quick update about radiation and mucositis.
Thank you, Emily, for a very nice presentation about the principles of radiotherapy and the management of mucositis in detail. Do we have any questions here, or we continue with the next session?
So, Dr. Nathan, can you allow me for one question?
Sure, please.
Yes, Emily, it has been very nice presentation. I am so thankful to you for joining us so early morning. And
Sure.
yeah, thank you. So my question remains, like in patients with severe mucositis, at my place in India, most people are fond of eating very spicy food. So
Great.
that remains a big challenge that they are not able to eat that. And if we give them some local anesthetic agent, the taste remains a masking effect of the taste. So what is your recommendation? How should we counterbalance this part?
That is such a difficult issue. And we have many patients. We have a very diverse population here in the Atlanta area. And we actually run into this on a regular basis. Many patients, as part of their culture, they're used to having very spicy foods. And if it's not bothering them, it's okay. It's not going to cause harm. It's just that many times, if they start getting to the point where they say, I just can't eat, it hurts, we try and help them understand if they can just reduce the spiciness, even, then they can do that. One of the concerns we have with using too much of the local anesthetic is then an issue with um, choking. And we don't want that to happen. So we're very careful about that. These magic mouthwash concoctions that we use can be helpful. But yeah, we really do try and help them figure out a way to flavor their food in other ways with herbs, other seasonings that maybe don't provide as much of that hot spice that they're used to, knowing that that's going to get better and they're going to heal and they'll get to go back to that soon after. So we try and help them through that.
Thank you.
Mhm.